Hello, my name is Ashra Khanom. I am a research fellow from Swansea University. I am pleased to have this opportunity to present the HERE study, the Health Experiences of Asylum Seekers and Refugees, Findings and Recommendations from a Qualitative Study. I am presenting this study on behalf of the HERE team. Firstly, I will present the context and background to the study, and then present the findings and recommendations. International conflict and human rights abuses have contributed to the rise in people seeking sanctuary throughout the world and Europe. A refugee is described as someone who has been recognized under the 1951 UN Refugee Convention as someone who is outside the country of his or her nationality and is unable to, or owing to such fear, is unwilling to avail himself or herself to the protection of that country. In contrast, an asylum seeker is someone who is seeking international protection but whose request for sanctuary has not yet been determined by the country in which they are seeking asylum. Wales has a long history of welcoming those fleeing persecution or war and is working towards becoming the world's first nation of sanctuary. People seeking sanctuary have been dispersed to Wales from other parts of the UK since 2001. However, numbers can fluctuate in response to international conflict and government policy. Home Office figures indicate that currently around 2,300 asylum seekers have been dispersed by the National Asylum Support Service to Wales. According to the Welsh Refugee Council, there are just over 10,000 refugees settled in Wales. Refugees and asylum seekers make up less than 0.5% of the Welsh population. What we know from anecdotal evidence is that many seeking sanctuary have unmet health needs and experience difficulties in accessing services. Within this context, Public Health Wales commissioned this study to investigate the health, well-being and healthcare experiences of adult sanctuary seekers in Wales, including views of recipients and providers, to establish what helped or hindered healthcare access and experiences of sanctuary seekers. We knew from the outset of this study that it was important to engage with this hard-to-reach group, so we used novel methods of public involvement to overcome these challenges. We aligned our approach to all 6 public involvement standards and collaborated with the third sector organisations, asylum seeking and refugee community, and NHS asylum support services, who were all included as valued members of our research group. We also trained 8 peer researchers from the sanctuary seeking community to help with signposting, data collection, and identification of participants. Between the peer researchers and the research team, we covered 6 languages. We conducted a mixed method study where we searched through the published evidence about factors influencing use of healthcare by sanctuary seekers in high-income countries. We recruited and trained a team of 8 volunteer peer researchers to collect survey data over 3 months. The survey was translated into 6 languages. We conducted 8 focus groups across Wales with sanctuary seekers and their supporters, and interviewed 32 health professionals and support workers delivering care to this group. As there was no accessible sampling frame for sanctuary seekers, we recruited opportunistic samples for the survey and qualitative research. Hence, we cannot generalise our findings to all sanctuary seekers. Also, we may have underestimated barriers to accessing services, since those using services were more likely to participate. Findings from the focus groups identified 5 themes. Not surprisingly, language and communication was one of the top themes. Other themes were presence or absence of trusted relationships, cultural understanding and values, structural barriers such as out-of-pocket expenses, and knowledge of the health system and how to navigate it. I will touch briefly on 2 of these themes. Firstly, taking language and communication. Many asylum seekers and refugees arriving in the UK often do not speak English. Therefore, communicating health needs can be challenging. We also know that refugee and asylum seeking children and young people are more likely to have been through particularly traumatic experiences. Many asylum seekers and refugees may not have the language to express their trauma and often present with physical symptoms such as headaches, back pain, anxiety, and gastrointestinal pain. In our study, we found that some people were refused mental health care because they could not speak English. Also, respondents said that during healthcare consultations, they often had to rely on someone they knew who could speak English, even if it was broken English, Google Translate, body language, or children. These difficulties are further compounded by the lack of available interpreters in healthcare settings. The quotes here illustrate some of the points raised by the focus group participants. The first one here says, I would not rely on body language or Google Translate because most of the time it translates things and it doesn't translate what you want to say, and I wouldn't risk it. You are not just buying a can of beans, you have to really communicate your message so that he or she knows what you are talking about. This issue must be taken more seriously. This person, speaking through an interpreter, said, If I had an emergency, I couldn't call 999. How could I speak to them? They wouldn't understand me in Arabic. And this other person here, speaking through an interpreter, also said, I asked them for an interpreter, but they said, Your daughter knows English, so there is no need for an interpreter. The doctors think that my daughter would understand the situation and they took her consent. I made a big mistake. Next time, I will not allow them to do anything without an interpreter. I have to understand what is going on. The second theme I would like to touch upon is the presence or absence of trusted relationships which supported people's access to healthcare. Participants mentioned how support workers, the asylum seeking nurse, and specialist health visitors helped them to make appointments, collect prescriptions from the pharmacy, make dental appointments, claim back money for hospital transport, and more importantly, facilitated face-to-face interpreters or telephone interpretation services during healthcare consultations. However, those who were refused asylum status were deterred from accessing care, often fearing immigration officials or not knowing that they could still access care, and relied on local pharmacists or went without care. Interviews with health professionals from across community, primary and secondary care settings showed that mainstream health professionals lack resources to care for these groups. Notably, they mentioned the lack of time to understand people's needs, not knowing much about the healthcare system from which the patients originated from. They also mentioned their lack of knowledge of the asylum process and people's entitlements to healthcare, and having access to available health information in appropriate languages. Surprisingly, many did not know of how to access interpretation services. However, health professionals recognise that this patient group often needed repeated contacts to receive appropriate health care. It was suggested that the pressures on the NHS, lack of services tailored to sanctuary seekers, and their isolation contributed to poor mental and physical health outcomes. However, some services use their own initiative to deliver outreach work. For example, a receptionist from an optician service visited community groups to talk about the service and the importance of regular eye checkups for children and adults. Parents were surprised to learn that children needed to have their eyes checked. They thought eye care was mainly accessed by elderly people. A quote here from a health professional captures the context within which health professionals care for sanctuary seekers. They bring their trauma with them that usually manifests itself as post-traumatic stress disorder symptoms, mild, moderate, and severe, and that's from past experiences. And in addition to that, I think what happens when they arrive here is that they face two main problems. One is the social isolation that comes with being removed from your usual community and not being able to work. And the other one, I would say, was the uncertainty and the hostile environment created by the Home Office around their house instability and the uncertainty around their asylum. The time for their asylum case to be heard is a big deal. Those two factors obviously factor into their mental health, but also their physical health. We recommend that the NHS should provide swift access to mental health support for trauma sufferers and provide foundation level mental health promotion resources to encourage self-help and mental well-being to prevent deterioration of mental health. We also recommend the NHS provide adequate and appropriate access to interpretation and translation services at all levels of the health service, and training should be available for staff to know how to access this resource. NHS should also continue to work closely with third sector organisations, asylum seeking nursing services, and designated health visiting services to enhance the ability of sanctuary seekers to navigate the health system and to improve their health literacy. We also suggest that particular attention should be focused on refused asylum seekers to ensure that they receive the care that they are entitled to. Finally, health professionals should be trained on the social, cultural, and legal issues affecting people seeking sanctuary to ensure access to care is not denied. Thank you for listening. Please leave your comments below. For more information, please follow the link here.